All right. Hello, everybody. Thank you so much for coming out to our special event today. Thank you for spending your lunch time and this beautiful day with us as well. My name is Stephanie Nava. I will be the moderator of this event. I will be reading your questions in the Q&A and in the chat. So if you have questions throughout the event, please put them in the Q&A or the chat. I will also be attaching an evaluation for this event towards the end of the program. Please fill out the evaluation form. We really value all of your feedback. And without further ado, it is my pleasure to introduce Dr. Benjamin Hampstead. Dr. Hampstead is the Stanley Berent Collegiate Professor of Psychology. He is the director of the research program on cognition and neuromodulation-based interventions. He is a staff psychologist at the Ann Arbor VA and the clinical core co-lead for the Michigan Alzheimer's Disease Research Center. His interests include neuropsychological assessment of aging, dementia, stroke, and epilepsy, cognitive rehabilitation, and non-pharmacological interventions for enhancing cognitive, emotional, and everyday functioning. And Dr. Hampstead, you are free to take it away.
Great. Well, thanks so much. And as Stephanie mentioned, thank you all for joining me. I gave a similar talk to this, a couple of years ago now. So I figured that this was a good chance for us to kind of update. So for those who tuned in a couple of years ago, you may see some similar slides, but I've tried to update each of the key areas that I touched on then, just because there's been a lot of really interesting and very promising research along the way. So with that, I want to assure everybody that I have no conflicts or disclosures. I do want to acknowledge the Department of Veteran Affairs and the National Institute on Aging for all of the funding support. And I think just to kind of, again, give that high level overview, we're going to just review some updated evidence for the role of exercise in terms of cognitive, kind of a protective and also an enhancing factor for cognition. Cognition-oriented treatments that I'll define a little bit more. And then one of the brain stimulation techniques that we're using a lot. So with that, I want to just very quickly review the overall context here. So this figure kind of nicely shows the different phases of what we see people presenting with in the clinic. So these are more of the clinical stages. Now, this does not touch on the underlying disease process or the other underlying changes in the brain that are leading to these phases. And briefly, we can think about it again in preclinical, which we could really kind of call quote unquote normal cognitive aging. This MCI phase, so mild cognitive impairment, it's characterized by the presence of cognitive deficits that are that have shown a decline from the person's pre-existing baseline. So a lot of times we'll ask people, is this the same or different than about 5 years or so ago? And if there's a decline, subjective report, and if we see objective evidence using neuropsychological testing, that supports a diagnosis of MCI. But the important thing here is, as this last bullet says, their everyday activities are relatively preserved. So people can still do pretty well on their own in their everyday life. Now, by the time those functional abilities, these independent activities of daily living, start to show some impairment, that really is when we tick over into this dementia diagnosis. And then we can kind of classify the dementia diagnosis along this mild, moderate to severe range. So again, I mentioned the clinical phenotypes of MCI and dementia. What's important is that dementia is really this umbrella term, and it's basically just showing that there are cognitive deficits and there's functional impairment. Now, the reason for those deficits can be broken down by the underlying etiology, or the causes, the things that are affecting the brain. So I believe this figure was from the Alzheimer's Center or the Alzheimer's Association that, kind of gives the general breakdown. What we're appreciating more and more through brain donations to our Alzheimer's Center and to the National Alzheimer's Center registries is that very, very rarely is there only a single disease process. A lot of times we'll see people with Alzheimer's disease and vascular dementia or vascular compromises or some Lewy bodies. And so I think that the field is really dramatically benefiting from the brain donations. So after people pass away, they're generous enough to provide their brain. And if they've been enrolled in our cohort, then we have years worth of data that we follow people with, and that we can kind of evaluate what were some of the clinical changes, those clinical phenotypes that I talked about, relative to what type of pathology are we seeing in their brains. Now, why non-pharm interventions? Of course, in the US, we have a very strong bias toward medications, I think for any number of reasons. So let's look at some of the efficacy, some of the evidence supporting or refuting some of the existing medications. And so we know that things like cholinesterase inhibitors have been approved for 20 plus years. And so there are a couple of older reviews now that I think, are still pretty relevant. And so one of these is that really the cholinesterase inhibitors produce small improvements in cognitive functioning in those with mild to moderate dementia. Those benefits basically taper off as the disease progresses. And then there are some significant side effects, including weight loss, some debility, some syncope, and these can obviously be very challenging and potentially even counterindications for those who are considered frail. Now, a lot of times we see patients who have that MCI, that middle phase, that middle clinical phenotype that I talked about, come in having been prescribed these medications, even though they're only FDA indicated, as last I was aware, for those with dementia. And so I thought this meta-analysis that basically looks at all of these studies that have been done and reported in the use of, say, these cholinesterase inhibitors in those with MCI, and it allows us to understand what is the overall effect of these medications. So as you can see, these effect sizes of 0.07 to 0.14, that's small. Basically, anything less than probably about 0.2 is considered pretty trivial. Up to about 0.5 is then a moderate effect, and anything above 0.7 or 0.8 is considered a large effect. So I want to keep these effect sizes in mind, because as I go through, that's going to be the best way that we can kind of compare the medication-based approaches with non-medication approaches. Now, there's been a lot of news lately about some of these monoclonal antibodies that are targeting the disease process. And this was a review that came out in 2021. And what you can see here is that these, hopefully my mouse is showing up, but you can see that this little diamond is to the left of this line. And basically what that means is in studies where people measured the change in one of the characteristic proteins, beta amyloid or tau, and those are the two proteins that define Alzheimer's disease. When people use these medications, the disease seemed to be getting cleared out of the brain. And again, these are some pretty nice effect sizes, right? The challenge, though, is that they are not changing cognition at all. So you can see basically 0.06, slightly worse cognition, 0.05, slightly better, 0.03. So they're very much in line with those existing medications. So it's interesting, right? Because we can clear the disease from the brain, but we're not necessarily changing the cognitive functioning of these individuals. Now, you may also recall that not too long ago, probably last summer, if I recall correctly, aducanumab made a big news splash. Sorry, and before I get there, I do want to point out that these monoclonal antibodies are associated with some amyloid-related imaging abnormalities, and there's a pretty high risk associated with those. And so that's why people who are using these have to have MRI scans on a regular basis and be closely monitored, because these can be potentially fatal side effects. They're still overall pretty rare, but they are there. And so that is something that physicians and their patients should be talking about. And you may recall, like I mentioned aducanumab last summer, lecanemab came out. This is the paper that came out in early 2023. Again, showing that people who used lecanemab or who were administered lecanemab showed a remarkable clearing of beta amyloid from the brain over the course of 18 months, right? Compared to a placebo. So there's a huge biologic effect of getting the disease out of the brain. But look what happens with cognition. We're seeing a relative slowing in the rate of decline. And depending on when you look at it, it could be about a 3-month delay to about a 6 or so month delay. So meaningful, certainly in the lives of our patients, but it's not improvement and it's not maintenance even. It's a slower rate of decline. And the extent to which any given person would notice this is still unclear. And I think that's what's really driving a lot of the controversy. So with that, let's transition then into some of the different non-pharmacologic approaches that are really showing a lot of good evidence. And so here we'll focus on exercise, right? The bottom line, by now, I'm pretty sure we all know this, exercise is good. And yet this is probably what a lot of people's home exercise equipment looks like. It's more of a storage device. But when we think about the effects of exercise, what the evidence suggests is that we really have these pleiotropic effects. It's good for pretty much all of us and pretty much every part of our bodies. So good for general physical health, for medical conditions, for mental health. I have a couple of question marks next to cognition because I want to talk a little bit more about this. But the bottom line is that basically all of us should be starting now, because at this point we know things like Alzheimer's disease start to show up in our brains years and years and years and years before any of those clinical symptoms emerge. So if we're able to keep ourselves as healthy as possible, and exercise is a single best way, I think, then we can try and delay any additional accumulation or any clinical decline as best we can. But of course, as with anything, persistence and consistency are the key features. So we all know if we lift weights really heavy for a couple of months and we get some great gains, if we stop doing it, it goes away. It's no different than if you take a blood pressure medication and your blood pressure gets under control and you stop using that medication, your blood pressure is going to go back up, right? So it's the same basic principle. And so this is where providers really need to partner with participants and really reinforce and follow up the adaptive behaviors of adopting exercise into kind of daily patterns. And so the NIA has some good resources related to exercise in older adults. And so the physical activity guidelines, I'll just hit on a couple of these. Basically, older adults should be getting 2.5 to 5 hours a week of moderate intensity. And then if it's more intense, you can basically cut that in half. And so there are additional benefits if you go above and beyond that, as long as people can handle it. And what's also interesting is that they also throw in muscle strengthening. So basically resistance training. And we're going to talk a little bit more about resistance training. Because a lot of times, at least a few years ago, it was really all focused on aerobic exercise like running or more endurance type of things, bicycling. But again, the evidence really supports resistance training as well. So good resources for patients. Again, NIA has these. You can see the website down over here on the right, and helps to provide some very approachable ways of increasing physical activity. I just thought I'd include these just in case we had any direct care providers in here. And then there are a number of really interesting studies really going on across the nation that try and use exercise, but provide it in a more culturally appropriate way. And so there are a couple that I've mentioned here that I think are really interesting that focus on Spanish speakers and on Black or African American individuals with African dance and a cultural immersion group. So some really interesting approaches that I think we can hopefully those studies will wrap up before too long, and we can then see what those benefits are. So with that, I want to then just briefly review what the evidence suggests. And so the US Department of Health conducted a large study that they completed back in 2018 that really reviewed all of the evidence here and that provided some general guidelines. And so here, a single bout of exercise was found to reduce blood pressure. Now, of course, this is temporarily. This isn't a permanent reduction, but if a single session can do this, imagine what happens if we do it over and over. It improved insulin sensitivity, which of course is impaired in those with diabetes. It improved sleep. We all know sleep is critical to our cognitive and mental health and just our overall physical health. And it reduced symptoms of anxiety. And gosh, over the past 3 years, we've had quite a bit of reason for anxiety across our society and throughout the world, right? With COVID, with economies, with wars, and so on. So again, then if you extrapolate to a more sustained exercise program, really what they found is that it improves sleep quality, increases deep sleep, which is so important for our restorative health, and it reduces daytime sleepiness. So people are less sleepy during the day. It reduces the risk of clinical depression, depressive symptoms, and the severity of symptoms. So basically, it helps people feel better. And not surprisingly, then there's a perceived quality of life improvement that people just feel like their lives are better overall. It improves the physical functioning. So there's reduced fall risk. There's reduced fall-related injuries. And this obviously then helps people maintain their independence for a longer period of time. Multiple other health factors and medical conditions reduces obesity, obviously, because we're burning calories and we're getting more physically active. It reduces the rates of dementia. Now, this is the all-cause dementia, whether that's Alzheimer's, Parkinson's, vascular, etc. It reduces the risk of any of those causes. Now, is that because it's specific to any of the etiologies, or is it just kind of the umbrella clinical phenotype of dementia? That still has to be determined, but it reduces the risk of dementia. You can see it reduces the risk of a number of types of cancers that I've listed there, and it reduces a number of age things that are very common in aging. So osteoarthritis, hypertension, type 2 diabetes. So again, multi-system benefits of exercise. And what's interesting is there's a lot of focus in Alzheimer's and related dementias on some of these inflammatory processes in our body. So basically our bodies may have this inflammatory process that then can contribute to our cognitive decline because it affects our brain. And what this meta-analysis that I'm showing you here shows is that markers of inflammation tended to really reduce, to decline in those who underwent exercise, extended bouts of exercise training. So you can see this with a couple of the markers, IL-6 and TNF-alpha, that they're on the left side of this dark black line, showing that there was improvement in those. And each of these little dots is an individual study. So you can see not every study showed this, but the overall impact, and that's the benefit of the meta-analysis, is that we can squish all these points together to get kind of a range of values. And we can see that overall, these things are looking pretty positive. Same thing, low density lipoprotein cholesterol improvement. There's a trend here for high density. So the good cholesterol improves. Blood sugars, triglycerides, definitely tend to decline, although not statistically significant. I'm still going to say, yes, this is a good reason to do it. And so then certainly total cholesterol values tend to decline. And you can see this may be a little bit muddied depending on the combination of LDL and HDL. But, excuse me, overall, there seems to be a pretty nice benefit. So what happens if we start early in the preclinical phase? I think that's where, again, as I mentioned earlier, we know that diseases are accumulating years and years and years, if not decades, before we develop any symptoms. So this is a good way to stay on top of it and to do as much as we possibly can. Now, there are some theoretical reasons that have been put forward, because some of the observations show that in animal models of Alzheimer's disease, exercise seems to reduce those toxic proteins, the amyloid and the tau. And here's a very complex schematic that suggests some potential reasons why. We're not going to walk through it. I wanted to put this up in case anyone is interested in this and would like to go down these different rabbit holes that explain each of these. But essentially, this model holds that exercise through a series of complex interactions may not only reduce the amount of amyloid being produced, but may increase the clearance. So we're producing less in our brains and we're getting more out of our bodies. And then there's a reduction in the number of tangles. Now, this is, again, a nice model that seems to be supported by animal work, but in human studies, it's been much less consistently supported, and the evidence is much less clear. Again, a lot of potential factors come in. How long was the intervention? How long did people exercise for? What type of exercise did they do? What clinical phenotype? And then were there biomarkers, right? Because if we have somebody with a mild cognitive impairment diagnosis that doesn't have amyloid or tau in their brain, and they have cognitive deficits for a different reason, well, then, of course, we're not going to see any changes in these biomarkers because they weren't there to begin with. So I think that's where the literature is starting to move to help us better refine our populations. And of course, baseline activity status. So if you take a marathon runner and you have them continue doing that, you've probably already reached a pretty high level of functioning, and you've probably come pretty darn close to optimizing a lot of these processes. Whereas if you take somebody who hasn't exercised since high school and they're now in their 50s or 60s, well, then you're going to have a very different trajectory, right? So I think we can ask two primary questions. Does exercise reduce the risk of developing dementia? Yes, we already covered that and provided some additional explanation for how and why. And then the second question that is all too often potentially misrepresented is, does it improve our cognitive or thinking abilities? And there, I'm going to give it a maybe, and you'll see why. But going back to some of the seminal works in the field, there's this review back in 2011 from Art Kramer and colleagues that really focused on aerobic exercise training. And this is typically after people have been assigned to do 3 to 6 months of training in older adults. And here the conclusions were really that it did improve executive abilities. So things like planning, inhibition, multitasking that people so often report difficulty with as we age. It increases the use of kind of these frontal and parietal brain networks that we know can decline with age. There were some changes in key areas of the brain and the size of different brain structures. Now, I want to then fast forward to a study that came out just last year that, again, did a systematic review and a meta-analysis that compared different types of exercise. And so what you'll see, and I'll walk through it with you, but here you can see this is the control intervention. So whatever that control intervention was for a given study. Then you have aerobic exercise, and you then basically take whatever this blue cell is and move it to the left to compare it with whatever other group you want. So aerobic exercise compared to a control intervention had a nice medium effect size for global cognition. Resistance training, so weightlifting, compared to aerobic exercise had more of a benefit. It wasn't statistically significant, but it's still, kind of nearing a medium effect size. And it had a large effect size relative to the control group. ME is multi-domain interventions, and MBE is mind-body interventions. So if we look at global cognition, you can see pretty much doing any of those relative to your control intervention is beneficial. When we look at executive ability, so these things I mentioned over here, both aerobic exercise and resistance training, so weightlifting, showed nice effect sizes, benefits compared to the control. And you can see that, again, there's a pretty notable benefit of weightlifting relative to aerobic training, and that only the weightlifting was beneficial for memory, which is interesting, right? Because all too often we think about aerobic training and cardio workouts as being the best for memory. This meta-analysis suggests that it's actually weightlifting that has the best effect for memory. So then if we think about weight training, I just absolutely love this picture. I wish I could do that much now, to be honest. You can see that here are a lot of different studies that were included in a slightly older analysis that basically showed the same thing: global cognition and executive ability improvement. And as I mentioned on the previous slide, we had some memory, but I think the big thing again is look at the duration. And this is the number of weeks that people were in these interventions. And this is the frequency. And so 1 to 3 times a week, typically for, couple of years, getting close to a couple of years here. So there's a huge range of things. And I think obviously the longer we do it, the more consistent we are, the better things will be. Now, with that, I want to provide that note of caution. So remember, I put that, does exercise improve cognition? I put the maybe. Well, let me just walk through that, because I think this is a paper that's posted on what's called Biomarkers. And so what's interesting is that you can see the different versions of the paper. And now this is up to version 5. And so presumably they're progressing toward publication. But here they're essentially reanalyzing a lot of these previous studies, and they come to some very different conclusions. And I'll just boil these down here, where they're finding an effect size of about 0.2 for cognition. And once they control for publication bias, there's really a very trivial effect. And so their conclusion is that the current evidence from randomized controlled trials does not support a causal effect of regular exercise on cognitive enhancement, although it does not preclude it either. So they're basically kind of walking this middle ground of, well, gosh, there's a lot of variability in what's being done and how it's being done. And so we're not convinced. And so they're taking a much more cautious tone. And I thought this was interesting because they said, and I quote here, "We strongly believe there's no need to appeal to the alleged as yet uncertain cognitive benefits of physical exercise, especially when the current meta-analytic evidence from randomized controlled trials suggests that even if the effect exists, it's notably small." So basically what they're saying is, gosh, there's so many other benefits to exercise. Let's not hang our hat on this being the sole reason that we try and get people to do it. Let's recognize all those other physical benefits, all those other emotional benefits that we know that are stronger. And let's not try and convince people to exercise by just saying, oh, it'll make you think better. So I thought that was an interesting counterpoint. So with that, again, we'll wrap up the exercise part of it, and I'll try and speed up a little bit because I have a lot more slides. And, and we'll try and not have our treadmills and our exercise equipment look like storage racks. Okay, so now I'm going to transition into cognition-oriented treatments. And again, here's the basic take-home messages: that we have a lot of different ways that we can potentially improve or maintain cognition, but we have to really understand what the goal is. I think that a lot of our data suggests that there are really important differences in how the different techniques work. And we need to take those into account when we're trying to figure out what to use and who to use it with. Typically, a therapist, very loosely defined, but an expert, is basically needed to help keep people motivated and help ensure that these training approaches are going as they should. And I always emphasize, and certainly am not alone here, but what's really important to the family and the patient or the participant, and those should really be the things that drive our use of these different techniques. So here, again, I'm not going to go through in too much detail, but I know that terms like cognitive training, cognitive rehabilitation, and cognitive stimulation are often used interchangeably in the literature. And I think this table does a nice job of helping us distinguish between them because they are not interchangeable. The goals are different. And so with cognitive training, we're really focusing on impaired cognitive abilities in either individualized or group formats, and we're really trying to enhance functioning in those particular areas. Cognitive rehabilitation is very patient focused. So we identify things that are causing them difficulty in their everyday lives, focusing on functional deficits that may keep them from having an optimal quality of life, or that keep people from living independently. And we use whatever tools we need in order to get people functioning better. And that could be as simple as teaching people to basically use oven timers on a consistent basis so that they don't burn their food. Cognitive stimulation is from much more advanced stage, which really is, as the name implies, meant to try and get people thinking and interacting more. And this is typically used in more residential facilities. And if we think about when to apply these, I've really tried to break this down into more of a color schematic. So green being more of the quote unquote normal cognition, the yellow being more MCI, and then the red being more in the dementia phase. And I think if we try and color code these, we can say cognitive training is and can be used across all the stages. Cognitive rehabilitation, because it's focusing on individually related functional deficits, is really more MCI into dementia. And cognitive stimulations is, like I said, mostly into the dementia stage. So I feel like this is, at least for me, a useful rubric that I thought I'd share. Now, keeping with the theme of reviewing large-scale evidence supporting or refuting these things, I like this study from some of our colleagues who are in Australia, Alex Bahar-Fuchs and Amit Lampet, who did a meta-analysis of meta-analyses. And so each of those meta-analyses, if you remember, looks at the effects from each individual study. Well, what this study did was take all of these different average effects from all of these different meta-analyses that have been performed, and they squashed them together to try and get an overall level of effect. And so here, what they found was that there were, generally speaking, some challenges with how much confidence they have in these findings because of methodologic quality related issues for each of the individual studies. But generally speaking, in studies that were higher quality, there were bigger effect sizes. So that helps reassure us that it's not just noise in the data. And so each of these points are different meta-analyses that have been done. And then, you can see that there's overall some really nice general positive benefits of cognitive training for healthy older adults, MCI, and dementia, as well as in Parkinson's, stroke, and mixed etiologies. Overall, these effect sizes are pretty nice. And when we look at them, they're consistently in that 0.3 to 0.4 range. So again, 3 or so times higher than existing medications. And this should be viewed as potentially some of our most robust evidence because of the way that they squished all these data together that account for differences in studies and how each individual meta-analysis was performed. So again, some pretty nice effect sizes. Okay. So this, some of you that have heard me speak before may recognize this, and this is really kind of how we view some of these cognition-oriented treatments and different approaches that we could use, and really, what is the underlying cognitive mechanism of action that we can rely on, and that may help us select things during specific stages of decline and different clinical phenotypes that may be more or less beneficial. And I think some of the best evidence, again, still comes from the active trial. 2,800 older adults randomized to one of 3 interventions or a no contact control group. They really only got 10 hours of training, and then some people got booster sessions. And I'm going to skip to the 10-year data. And what it shows is that people who were randomized to this processing speed training using this, what's called a useful field of view task that I'll describe more in a minute, they show these persistent benefits even at 10 years. Same thing, the reasoning training group shows these persistent benefits at even 5 years, and depending on who you compare it to, even at 10 years. And same thing with the memory group, improvement at 5 years, and depending who you compare it to at 10 years. Now, the interesting thing is that this is the control group, and you can see that they deviated. They used to be low, if not right in the middle of the other two treatment groups, but they deviate at this time point. So compared to the other two treatment groups, memory training had a benefit for memory. And I think this is one of the important take-home points, is that we're seeing very domain-specific effects. If we train people in memory, their memory gets better, but their reasoning or their processing speed don't. And that's okay, because that tells us that we have a specificity of results. And a lot of times people complain that there's no transfer effects, but that's all right. That's the same as saying, oh, well, my blood pressure medication didn't lower my cholesterol, so it must not work. Well, it wasn't designed to lower your cholesterol. It was designed to lower your blood pressure, and it does that. The lack of transfer in that case, I think, is pretty analogous, and it makes us appreciate that our thinking abilities, our cognitive abilities, are not a unitary concept. So I mentioned this useful field of view training. This probably has among the most evidence supporting it, just because it's one of the things that people have really looked at over the years. And so the idea, and this is an old-fashioned version, but the idea is you have a central fixation point, and then you want to respond as quickly as possible when the same stimulus appears in the periphery. And what's interesting is, again, that when looking at the 10-year data, the group who received this training reported much less decline in their activities of daily living relative to the other treatment groups and relative to the control group. But it still certainly looks like these other treatment groups had a nice effect relative to the control group. So UFOV seemed to potentially be pretty effective at preserving IADLs at 10 years. Now, a couple of previous studies actually used this paradigm and then looked at state driving records and found that those who underwent UFOV training showed a 50% reduction in at-fault crashes over 6 years. Edwards and colleagues found that those who underwent UFOV training were 40% less likely to cease driving over the subsequent 3 years. So again, there's some really nice real world ramifications of these data. And of course, with all of this, we certainly need to replicate and extend this work. But I think it's pretty promising. Now, UFOV was actually, this is from a paper that came out a few years ago that's claimed that UFOV training had a 29% reduction in the risk of dementia after 10 years. And you can see that this p-value is just below the typical 0.05 threshold. But what's interesting is that memory and reasoning training were not statistically significant, but they reduced the risk by 21%. So you can see the hazard ratio, 0.71 versus 0.79, and the raw number of people is only 4 different. So if it's my money and if it's, you know, my parents and me at some point, I'm going to say these are still definitely worth doing, even though they don't reach that statistical significance. To me, these are pretty striking that they're still worth doing relative to control. So one of the things that we often are asked about are these computerized cognitive training. And this is an old series of pictures. There are tons more now, and I'll give you a couple of examples in a second. But these typically require people to play these different games and these training exercises for 20 to 60 minutes a day for multiple weeks, and they can be either supervised or at home. But the duration of the training, the timing of the training, the motivation tends to wane. And that's why, again, having the therapist or supervision, loosely defined, is so important in maintaining any benefits of these. And so this is from Lumosity, that you may recall got into some trouble a number of years ago with an FCC fine for making some claims they couldn't back up. So they've pulled those back, but they offer a number of these different tasks that are, you know, processing speed, memory, problem solving, attention, flexibility. And then one of the other ones that's very common, Brain HQ, has a subscription format and it's adaptive, and it basically will keep challenging you so that you don't get bored and that you perform at a certain threshold, and then it'll make things harder or easier to keep you at that general level. So these methods have really advanced, and there's a lot of debate in the literature. But again, I'm going to turn to our colleague Amit Lampit, who's really done some beautiful meta-analytic work here. And so they looked at, this is an older study that was reviewed 52 studies before 2014. And you can see the overall benefits of these things across different cognitive domains are in that 0.2 to 0.3 range. Now, what you'll notice is that verbal memory is kind of the weakest effect here. There were no effects on executive functioning or attention, which was interesting. But if you think about the nature of interacting with your computer, you're going to be doing more visually based tasks rather than verbally based. So I think that probably accounts for some of this discrepancy. But overall, this is a pretty promising effect that, again, is bigger than what we see with medications. And so what they actually said was that their data suggested that 3 sessions a week seemed optimal, at least 30 minutes per session seemed best, and that really you needed to have group-based or supervised training because at home was not effective. So this has been updated recently, again, Amit Lampet being the senior author, and this kind of looked at all of the different studies that had done meta-analyses with computerized cognitive training. And really what you're seeing again is that 0.38 effect size. If we boil it all down, these computerized cognitive training tasks have effects that are pretty consistent with all those other cognition-oriented treatments that we've talked about. We've been able to use some of these tasks to teach specific information. And so we've done things like spaced retrieval, which, as the name implies, you systematically increase the time between when you give somebody something to study and when you test their memory. And by increasing that, in this, you can see that it was a curve where we initially, the first time we presented something, we had a 0-second delay, and we just made it a 1-second delay, and then a 2, and then a 4, and then an 8, a 16, 32, 64, 128 seconds by the 9th trial. So we're systematically building that memory by gradually increasing the time that people have to remember it and giving them lots of practice doing this. And this is very effective. And the next slide, I'll show you some evidence for this. But we've also used this technique that's called vanishing cues. And so what we do is remove some hints each time somebody successfully remembers the memory. But if they don't remember it, we give them a little bit of help. And so again, we're kind of taking things away as they're doing better, giving them a little more support to help them function better. And the way that you could do this was to think about this guy with a really bad facial hair and probably a bad life choice to grow it out this long. And on each subsequent trial, if you say the name correctly, you can have a letter removed, and you can keep doing that until eventually you have very few cues remaining. But then let's say the person can't remember the name or gives the wrong name. Well, then you can systematically increase the number of cues that you provide until they're able to do this pretty independently. And so again, this is something that we've used very successfully across a number of studies. And so in this study that we just published in Alzheimer's and Dementia last year, we compared spaced retrieval with some of these internally based mnemonic strategies. And so the strategies, we basically taught people to identify a feature in the environment that was close to where a targeted item was placed. And then they just developed a verbally based reason that linked that feature with, in this case, the object. And then the other group was randomized to this spaced retrieval. And what you can see is that the groups were no different at baseline, and both groups showed significant improvement in their memory for information using these approaches. But the magnitude of benefit was far greater for people who used the strategies. And what was really cool is when we looked at the patterns of brain activity, we saw an increase in brain activity for those who learned information using strategies. And this is the hippocampus. And this is one of the key structures that's affected by Alzheimer's disease, because it's critical for forming new memories. And what we see is that we partially restored activity in the hippocampus, and it was now actually communicating with different brain regions far better than it was before training. And this effect was very specific to the strategy training, because in the spaced retrieval group, we're seeing what's called repetition suppression effects, where we're actually seeing less brain activity after training compared to before. And that's because people were processing things more efficiently. So again, this suggests to me that we can take these different techniques, apply them differently, depending on where people are at with the disease, what parts of the brain are affected, and we can have a more individualized, tailored approach. So some colleagues have similar findings where Sylvie Belleville up in Montreal has a really beautiful program. It's called Memo Plus. This is certainly available. And their data, again, showed that when they randomized people to this memory training, the cognitive training, or a psychosocial or a no contact control group, so they had an active control and a no control group, you see some very specific effects of this training on new learning and memory, on self-reported memory use, but not necessarily on things that weren't trained. So activities of daily living, self-reported memory, well-being, anxiety, depression. And I think the other big caveat that I'll throw out there is look at these scores. These are all basically well within normal limits. So people were not selected who had anxiety or who had depression. And so what I've seen is sometimes critics in the field will critique these strategies or these cognitive training approaches for not addressing depressive symptoms. But in this case, there were no symptoms to address. So we have to be cognizant of what the study criteria are for enrollment and what we can conclude as a result of that. So just to push it out into cognitive rehabilitation, as I mentioned, this is a very individualized focus group, and this study was from Linda Clare and colleagues. This was a parallel group, multi-center, single-blind, randomized control trial that compared cognitive rehabilitation, where people randomized to that group had very specific goals, things that they wanted to do: burn less food, remember to bathe consistently, et cetera, et cetera. And they developed programs to help people do that. And they included 475 people. And you can see a pretty good follow-up rate at 3 months and at 9 months. And the cognitive rehab involved their care partner, and they had 10 weekly sessions over 3 months. Long story short, basically, look at these effect sizes. And this is when how the participant feels. Did they achieve their goals? Were they satisfied with their goals? And what was their care partner's impression of, did they achieve their stated goals? And you can see these effect sizes are big, right? So when done in a very patient-centric way, we can really see a lot of benefit. One of the things, I know if we have a mixed audience, but I did want to kind of throw this out there, that one of the things that Alex Bahar-Fuchs, that I've mentioned before, and I are collaborating on, is this repository of these cognition-oriented treatment studies. And this platform is really cool because we're extracting data, entering it into a database, and then what it does is let the user query and actually perform meta-analyses automatically, and then it spits out a PDF for you so that you can understand how beneficial are these things. So what we did here was looked at just studies that said their primary focus was on memory and that focused on patients with MCI. And then what it does is look across these different cognitive abilities and gives us a sense of what is our effect size. And so you can see things like memory, whether it's verbal, it's visual spatial, or just general ill-defined, that improves when interventions target memory. But mood doesn't really, psychological outcomes, loosely defined, don't. And so again, we're getting the specificity of effect. And again, the overall effect size was in that 0.2 range, so not too far off from what we've seen before. So I think that's a useful tool that I just wanted to make people aware of. So again, wrapping up this section, and I'll very quickly go through some of the brain stimulation in just a minute, but take-home messages that we already kind of covered. Now, brain stimulation, I'm going to go through this fairly quickly because at this point I've given you a lot of information, and I think this is probably honestly still by far the most experimental out of everything, right? Because it's a very overall a pretty young field, and there are a lot of different approaches. So what I can say is that the technique we use a lot of, transcranial direct current stimulation, is safe, it's well tolerated, and it's pretty inexpensive. We know that it can have effects on your brain, and it seems overall to have some promising impacts on our thinking abilities, but there's still so much work to be done that I'm going to also give that a maybe. What we don't really have are very well-established treatment parameters. So a lot of what we're doing is more kind of tenuous and building that evidence base. And I think that, again, for our program here, that's one of the big things. We're working on these methodologic factors that will help us translate this into a clinical practice. So there are a lot of different devices that if you work with people, you may get asked about a lot. I'm not going to comment on any individual system, aside from saying just make sure that folks are actually looking at the evidence, and that I'm a big advocate that, especially for these things, that there's a knowledgeable expert that's involved, rather than just giving this to anyone, because there are some potential downsides to that. And the basic idea is that we put electricity in through one type of electrode called an anode, and then we pull it out through another type of electrode, a cathode. So it basically flows in here and then out there. And doing this, we can use MRI of the brain, and we can model where that energy is flowing through the brain. And the basic idea is that it's making neurons in our brain more or less likely to communicate with one another. So this is a review that came out in 2021 that looked at different articles using some of these, using tDCS and neuromodulation in general. And what they basically found is that in the studies reviewed, you can see that the overall effect size, 0.63, right? So that's pretty robust compared to some of the other effect sizes we've been looking at today. And that in different cognitive domains, you see different magnitude of effects, but they're all still pretty notable. But you can see there's still very few quality studies that are done. So a more recent one that came out, well, actually, this is just a different study. 24 studies included versus really 4 focusing on memory in the prior one. But again, the take-home message is in that same general area, right? So a 0.625, so pretty darn consistent with that 0.63 we saw before. And then over extended delays, we're looking at 0.4 effect size. Colleagues here, Dr. Alex Jordan and I had a project where we basically showed that in patients with MCI, we were able to normalize the patterns of brain communication in patients with MCI and brought them up to levels that were consistent with where cognitively intact older adults were. And a former postdoc, Kitty Lengu, and I showed that really we could alter some neurotransmitter levels in the targeted area, but not in a region where we didn't stimulate. So showing good specificity of effects. So these are some of the things that we're working on, and we have this ongoing randomized controlled trial that is enrolling patients with mild cognitive impairment or dementia of the Alzheimer's type. And our goal is to identify how much should we be using, how long should we be doing it for, whom should we be doing it with, and we're using disease biomarkers, amyloid and tau PET scans, so we can really try and determine, is it the disease or is it the clinical phenotype or the interaction between that we should be using when dosing this. So again, this is safe, well tolerated, has some good physiologic effects, but you know, we need to really have some additional work to translate it. So the overall take-home message here, we really need to be realistic about our goals and expectations. We need to leverage information that related to how the brain is working so we can identify and select the best. And again, one size is not going to fit all, just as there are all sorts of different medications to control your blood pressure. And we're all perfectly comfortable saying, well, gosh, for me, this one works, but that one doesn't. But with some of these other interventions, we kind of hold that against them, that if it doesn't work for somebody, then it must not work. But that's not really the case. So want to really acknowledge colleagues and the team, and certainly the Alzheimer's Center, and definitely encourage you to stay in touch. So I know with that, we have just a couple of minutes left. So if there are any burning questions, I'm happy to answer them. And if not, I'm certainly happy to let people have a few minutes back in their busy schedules. Let's see. So I see one of the questions is how do we access some of this? I guess it depends which techniques we're thinking about. Again, I tried to provide a number of resources in here. I think from some of the cognitive training work, those computerized programs are very easily available. Again, the caveats are that there are some limitations to that. Things like exercise, certainly there's no shortage of personal trainers and others. Certainly consult your doctors before starting that is the mandatory caveat there. With some of the brain stimulation, we're doing a lot of it. So you can see our website right there. Definitely reach out if you're interested in learning more about some of the brain stimulation techniques. And so it's hard for me to know how best to answer that question, but again, try to give some key information throughout the slides. Okay.
All right, well, if there aren't any more questions, thank you so much for coming out today. And thank you, Dr. Hampstead, for the wonderful talk. And this event will be up on YouTube in the next week or so. I have the recording of it, so keep your eye out for that.
Thanks, everybody.
Thank you.